a three-legged stool, 3 legs. So we'll put the patient on it, just committing the patient to the ventilator, and then we'll manage the patient on it to make sure that they're stable until the disease that caused them to be put on the ventilator has resolved, and then we take them off. So we've done putting the patient on the ventilator, we've done management, and now we're doing discontinuation of mechanical support. I want you to know that there are 2 ways that we can do that. That's what they call disconnection, and there's what they call winning. Now, disconnection is like when a patient is put on the ventilator for a reason, any other reason other than lung infection. There's nothing wrong with their lungs. Like, you're going to have surgery done, you get intubated just for them to do the surgery. I mean, you don't have any problems with your lungs. Okay? Anytime they give you general anesthesia, you have to be intubated. Okay? Now, patients like that, when they wake up, we don't need to wean them. We can just yank the ET tube out, and they should do fine. There's nothing wrong with their lungs. So these are patients, post-operative patients, drug overdose, effect of anesthesia, even epiglottitis. Epiglottitis is not inside the lungs, it's outside the lungs. So once the swelling goes down, we remove the ET tube. Okay, that's called disconnection of mechanical support. Now, weaning is different. Weaning is gradual withdrawal of mechanical support. Usually, you have a lung disease, okay? And you've been on the ventilator for a while. We're going to gradually, reduce things until you wake up and start breathing on your own, okay? It is a lengthy process compared to disconnection, and patients usually will have a lung disease. Now, criteria for determining readiness to win. When do you know that a patient is ready to win? Okay? The first thing is the disease process that caused the patient to be put on the ventilator is resolving or has resolved. Like, I intubated my patient because of pneumonia. Well, before I start weaning them, I want to make sure that the pneumonia has resolved, or at least it's resolving. I intubated them because they went into respiratory distress because their blood sugar went up. Well, before I start weaning them, I want to make sure that their blood sugar is back to normal. We intubated them because they have pulmonary embolism. Well, you want to make sure that it's done. Okay, so that's the first thing that we look at. Okay, before we start trying to win a patient. The second thing is that before you're going to win a patient, you want all the sedatives to be reversed. Because you want the patient to be awake, okay? And he's able to do some spontaneous breathing. Like, there is a drug called Diproven, okay? It's a drug that we use to knock a patient out when we don't want the patient to do anything or move around or whatever. We knock them out. So if they're on Diproven and you start weaning them, okay, you have to make sure you decrease the Diproven level so that the patient can wake up. Okay? So we have to reverse all the sedatives. If they have a drip of Ativan going in, we want to stop that or minimize the amount going into the patient. Okay, so that they can wake up. Yeah, patient must be alert and oriented. If you are alert and oriented, you'll be more conscious of your breathing. We can come to you and say, well, take a deep breath, and then you do it. But if you're not oriented and alert, well, you can't do it. Patient must have spontaneous breathing. There's something called apnea trial. Okay? or spontaneous breathing trial. Okay? What they do is, if a patient is on ACVC or SIMVC, and the ventilator has been breathing for them, okay, we want to do spontaneous breathing trial, what we're going to do is we'll quickly switch the patient to pressure support alone, where they're going to breathe on their own, and then once you switch them to that mode, then you see whether they're going to wake up and start breathing on their own. If they can't wake up and start breathing on their own, then they're not ready. But if they're awake and start breathing on their own, then that will be good. Okay? So the patient has to have spontaneous breathing. Because what you're going to be doing here is turning down the ventilator rate gradually. And when you start turning down the respiratory rate on the ventilator, if the patient doesn't pick up, breathing on their own, that's going to cause their CO2 to rise. Okay? Adequate pain control, yeah. If the patient is in pain, we want to give him a low narcotic agent, morphine or Dilaudid or Demerol, just to control the pain, but you don't want to over-sedate the patient now. Okay? Because that will put them on the other side of the equation. Stable vital signs, yes. They have to have normal oxygen saturation, normal heart rate, normal blood pressure, okay, before you start winning them. You cannot start winning somebody who has a blood pressure of 190 over 100. You cannot start winning a patient who has a heart rate of 135. Okay, you cannot start winning a patient who has a blood pressure of 80 over 60. So the vital signs have to be relatively normal. Absence of arrhythmias, abnormal heartbeat. Well, you cannot start winning a patient that has some PVCs. Okay? You cannot start winning a patient that has tachycardia, sinus tachycardia. You cannot start winning a patient that has atrial flutter or atrial fibrillation. Okay? Protective airway reflexes must be intact. That is true. I think we have 3 of them. We have pharyngeal. We have pharyngeal reflex. Pharyngeal reflex. And then we have what's that? Laryngeal reflex. And then we have tracheal reflex. And then we have carinal reflex. These are called airway protective reflexes. Now, pharyngeal reflex is for gagging and vomiting. Like if I was to put something at the back of your throat, you will gag and try to protect your airway. Okay? Which, of course, will result to a vomiting. You'll vomit. Laryngeal reflex is associated with the closing of the vocal cords. The vocal cords will spasm and try to close up to protect something from getting inside your airway. And then we have tracheal reflex, that's cough. When you stimulate the tracheal reflex, you cough. Something goes inside your lungs, you're going to start coughing right away to expel it. And then we have carinal reflex, that's also cough. Okay? So, when we're giving you sedation, you lose your reflexes this way. The more sedation that will give to you, you're going to lose your laryngeal reflex first, and your ability to gag. You lose the laryngeal reflex, you lose your tracheal reflex, and then you lose your cranial reflex. If you lose all your 4 airway protective reflexes, that's called general anesthesia. You can't control your airway. They have to intubate you to protect your airway. When you start getting them back, that now the drug is beginning to wear off, you get them back this way. So that comes back first, that comes back next, that and that. So usually what some people do is, if somebody has been under very severe sedation, before they try to wean them or extubate it, they may take like a tongue blade and just stick it at the back of their mouth and see if they will gag. Yeah, that can be done, but that is not commonly done, because the caveat about doing that is, once you stimulate it, the pharyngeal reflex, they can gag and vomit, and then maybe aspirate the vomitus, and then what you got is aspiration pneumonia. But that is practiced, okay? And if you want to see that the patient is completely awake, okay, they have to have their pharyngeal reflex, okay? I mean that they will be able to protect their airway. Electrolyte, all the electrolytes must be within normal limit. 3 of them are what you really need to know: sodium, potassium, and chloride. Potassium is 3.5 to 4.5. I remember with the normal CO2 level, 35 to 45, with the dot in the middle. And then the sodium is 135 to 145. And then all you gotta do is you put one in front of the normal CO2 like that. And then chloride, I remember, with normal range of PaO2, okay, 80 to about 100, 108, somewhere there. So chloride is about 80 to 108. Patient's level of consciousness, yeah, they have to be conscious. Patient must be afebrile. If they have fever, you can't wait to extubate, because fever increases metabolism. If you have, it's a sign of infection, it increases metabolism, and metabolism requires oxygen. So the patient may not keep up with the amount of oxygen that is needed for that increased metabolism. And then they may start having lactic acid, okay, because of anaerobic metabolism. And then if they have chest tube, you want to make sure there is less than 100 milliliter drainage for the chest tube in 24 hours. Because if you have something inside your pleural space, let's say you still have plenty of fluid here, pleural effusion, or maybe pneumothorax here, plenty of it. Well, that's under pressure. That will compress your lungs. Your lungs cannot expand when you breathe. So ventilation is not going to be good. You know, and then if ventilation is not good, oxygenation is not going to be good. So usually what they do is they will clamp this for at least 24 hours and see how the patient is going to react to it, okay? Before you try to extubate them. You have to have normal blood gas, acceptable normal blood gas. You remember the one for COPD patient? The CO2 is in the normal range No, pH is in normal range. CO2 is high, bicarb is high. You estimate the patient 7.36, 80, 61, 39. That kind of blood gas. You estimate your patient. You can go a while and know that CO2 is still high. Okay, so that's COPD blood gas. Absence of anemia or abnormal hemoglobin. Well, anemia is low red blood cells or hemoglobin or hematocrit. That's what we define it. You have low red blood cells or hemoglobin or hematocrit. That will impair oxygen transport. Okay, the patient will end up having hypoxia if they don't have adequate hemoglobin. So we don't want to extubate them. Or you have abnormal hemoglobin like carboxyhemoglobin or methemoglobin. That will also impair oxygen transport. The hemoglobin cannot pick up oxygen to transport it down to the tissues. So if somebody has high carboxyhemoglobin, you don't extubate them. All right, so the the ventilator, the SIMV is the winning mode. Okay. Let's say your patient is on ACVC, and the doctor comes in and says, "Well, I want to start winning the patient." You're going to switch them to SIMV-VC mode. Okay, because on the SIMV mode, the patient can breathe spontaneously. They can get true spontaneous breaths. But that's not the case with ACVC mode. All the breaths, whether the patient is triggering or the ventilator is triggering, will be a breath with the set tidal volume. Okay, but on the SIMV mode, during the spontaneous window, when the patient breathes on their own, they will get their own spontaneous tidal volume. Okay. The SIMV allows the patient to exercise their muscle, their ventilator muscles. Okay, remember you have them on ACVC mode, the ventilator has been doing everything, so they're not using the diaphragm. Okay, so we switch them to the SIMV mode so that they can start, getting stronger with their respiratory muscles. Okay? So this is what, just remember the SIMV mode that the patient breathes spontaneously, and that's what this is all about. SIMV rate is gradually decreased by 2 to 4 breaths per minute to encourage the patient to breathe spontaneously. That is true. So you have your patient on the SIMV mode, say a rate of 12. Okay? If you decrease it to 10, the normal response is that the patient would breathe 2 more breaths of their own. If you decrease it from 12 to 8, then the normal response is that the patient is going to pick up and breathe more on their own. Okay? If you are decreasing the ventilator rate, the SIMV rate, but the patient is not picking up and breathing more on their own, then they're not ready to be weaned. Because even if you decrease it to 6, they're not going to breathe, and therefore your CO2 will start rising. So that's the normal response. As you decrease your ventilator rate, the patient should be breathing more on their own to maintain the same minute volume. Okay? Pressure support may be added to increase patient's spontaneous tidal volume. Yeah. On the SIMV mode, you can set pressure support with it. So that when the patient does breathe on their own, on that mode, they are going to use the pressure support level that you set to decrease airway resistance so that they can get a bigger tidal volume on their own. Okay, so that's what the pressure support does. Win rate to below 8 breaths per minute before switching to pressure support. Now there is a freestanding mode called pressure support. So my patient is on SIMV VC pressure support like that. Okay, so I have a pressure support of let's say 10 set, the rate of 12. So I want to win my patient, so I'll turn it down to maybe 10. And then I'll watch the patient and see how the patient is reacting to that. If the patient gets tachypneic or tachycardic or in distress, moving around, then that's not good. I have to put it back. Okay. But now let's say that I have it on 10, but everything is fine, O2 saturation is fine, respiratory rate is fine, everything is fine. Then I turn it down to 8. And then I monitor my patient. Okay? And that's still doing fine. Okay? The next thing I can do then is I can switch it to pressure supported load. That mode that says PSV CPAP. We're going to do that next Tuesday. Pressure supported load. So now the patient is going to be on pressure support of 10, and they're just breathing on their own. All the breaths will be theirs. And then you start within the pressure support. You can make it 8, turn it down to 6, and then once you get to 5, and the patient is still doing fine, then you can extubate your patient. Okay? So now we'll go from like assist control, SIMV, pressure support. Okay? If you want to win them some more, then you put them on TPs. That's oxygen therapy before you remove the ET tube. You just want to make sure that once you extubate your patient is going to do very well and not have to go back on the ventilator. Okay? So remember that to begin winning, I always switch to SIMV mode. SIMV mode. Here's that pressure support. Okay? On pressure support mode, the patient controls their respiratory rate. You don't set respiratory rate there. They control their breathing depth. They control their eye time. They control the flow. They control the tidal volume. The only thing that you control there is the pressure support level. Okay? This mode is patient triggered, pressure limited, and flow cycled. Okay? Now, if you remember, on the spontaneous mode, there's something called the expiratory sensitivity or the inspiratory cycle off. I'll show it to you on Tuesday. So that's how we cycle off pressure support modes. When you set your expiratory sensitivity, you're trying to determine the percentage that the flow will decrease to before the breath cuts off. Okay? Guideline for setting pressure. How do you know what level of pressure support to begin with? Set to appropriate level to eliminate walk-up breathing. Okay, so if my patient is going, and then I instituted a pressure support of 15, and then that stopped. Well, that's a normal level of pressure support because that just removed airway resistance. Okay? The reason the patients breathe that way is due to increased airway resistance. They are trying to drop the pressure inside their lungs to negative so that they can breathe. So they have to work really, really hard for that. Set to appropriate level to maintain normal respiratory rate. Well, this is, alveolar ventilation is based on mini volume. I mean, mini volume is more important than tidal volume. So mini volume equals tidal volume times respiratory rate. So there are two ways that you can maintain your mini volume to control your CO2. It's either that you're breathing in deeply or you're breathing very fast. So if you are not breathing in very deeply, then your respiratory rate will go up so that you can get your mini volume. If you're breathing in very deep, then your respiratory rate drops. So the higher the tidal volume, the lower the respiratory rate. The lower the tidal volume, the higher the respiratory rate. That's how you maintain your mini volume. So in other words, I can use that. I can go up. If I set this level of pressure support that is going to be giving me this amount of volume, and my patient's respiratory rate is in the normal range. Well, that's a good level of pressure support. Okay, because now, if the pressure support level is very low, the patient's tidal volume is also going to be very low. And if their tidal volume is very low, their respiratory rate will go through the roof. Okay? So that's where we check it. Once they're breathing, they have normal respiratory rate, then that pressure support level must be getting a good enough tidal volume for them. Initial setting should be equal to or greater than transairway pressure. Well, transairway pressure is the difference between your PIP and your plateau. Your inspiratory pulse like that, you see that. That is your PIP, that is your plateau here. So this is your transairway pressure. Transairway pressure. How do we calculate airway resistance? It's PIP minus plat divided by flow. So the difference between your PIP and your plateau is the pressure due to airway resistance. The higher the difference, the more airway resistance that you're going to have. So if I know that my transairway pressure is 10, pressure due to airway resistance, and then I set a pressure support of 10, well, pressure support is designed to eliminate airway resistance. They will cancel each other out, so you have 0 airway resistance now. So my patient is on the SIMV pressure support when I can do my inspiratory pause. I get my plateau. I will subtract my plateau from my PIP. I get my transairway pressure, then that will be the beginning point for my pressure support. If it is 20, then I want to start with pressure support of 20. If it is 15, I want to start with pressure support of 15. Okay, so that's another way that you can tell that the pressure support is enough. Any questions about that? Monitor the following as pressure support level is waned. So let's say that the pressure support of 20, now you're going to start winning it down because you have to get down to 10 or 5. Okay, when the other way down, if it's down to 10, well, that's almost like spontaneous breathing. If it's down to 5, yeah, that's almost like spontaneous breathing. Okay, anything above 10 is still very high, really. Okay? You monitor your spontaneous rate. Because if I decrease my pressure support level, that affects my tidal volume. Okay? And then if my tidal volume drops a lot, my respiratory rate will go up. Let's say my patient's respiratory rate jumps from 20 to 36. That's increased walk-up breathing. That means that they have shallow breathing right now because I decreased the pressure support level. Any questions about that? You can monitor your spontaneous tidal volume as well. We know normal tidal volume, normal spontaneous tidal volume, 5 to 6 milliliter per kg. Well, if I turn down my pressure support level, and then all of a sudden my patient's tidal volume drops, let's say from 400 to 200, okay, that's not good either. If I calculate that out, and it's less than 5 to 6 mils per kg, then that won't be a good tidal volume for the patient. And then you can monitor your vital signs as well. If you decrease your pressure support level, your tidal volume goes down. That means your ventilation goes down. If your ventilation goes down, your oxygenation goes down with it. Your oxygenation goes down with it. Your heart rate goes up with it. Your blood pressure goes up with it. So it affects your vital signs as well. Okay? Yeah, TP's trial is oxygen therapy. Okay? It's this kind of setup. you're gonna get, large volume nebulizer. It goes like that, that's your blue tubing. And here you're gonna have what they call the, Briggs adapter. Or they call it T-piece as well. Oh no, T-bar, some people call it T-bar. So it looks like this. And it looks that way, that plastic, that looks like that. So you have that here, at the end here. And then, on this end, you have one length of corrugated tubing like that. Have you ever seen this kind of setup before? No?
For a fund patient.
Oh, God. We're gonna make you go to UNM, you know. Did you ever go to UNM?
Yeah. Didn't see that.
Okay.
No.
Okay, sometimes maybe you just don't have a patient, but now, and then here, this portion here hooks up to the ET tube, or tracheostomy tube. So all that the patient's breathing is oxygen. You want to monitor them for a while to see how well they're going to do off the ventilator. If they're doing okay, then it's time to extubate them. This is the traditional way of weaning the patient from the ventilator. Even before the SIMV and pressure support and all of that became available, what we did was we took them off the ventilator no matter what mode, and then we put them on T-piece. Okay, but now you go from like assist control mode, you switch them to SIMV plus pressure support. They're doing fine, you switch them to pressure support alone. And then if that's not enough, you think that for some reason the patient still can make it, then you want to try them on T-piece. Okay, it's just oxygen therapy. Okay? It's easier because there is no resistance to breathing. It is small, so it's smaller. Now this is a CPAP on the ventilator. Okay, that's a winning mode. If you go to that mode, that says pressure support, that's what we're going to do on Tuesday, CPAP. Like that. So what we're going to do is we're going to select that mode, and then we set the pressure support level to 0. So the patient will just be on PEEP, CPAP, because they're going to be breathing spontaneously. Okay? So this is, the CPAP is harder than the pressure support mode because you don't have anything that is reducing the airway resistance imposed by the artificial airway. So it's harder. So if a patient can do so well on CPAP alone, they're very good to come off. But they're not getting any help. They're breathing without that airway resistance. Okay? When I was a staff therapist, I never really liked, putting my COPD patients on CPAP. Because the reason for that is that the COPD patients already have high airway resistance. And normal airway resistance, when you're intubated, is like 5 to 8 or 5 to 7. Emphysema alone, even off the ventilator, emphysema will give you like 14 to 18. Okay, so now, on the ventilator now, you put them on CPAP, so what that means is that the ventilator is over there, they're gonna have to suck in really hard to turn that ventilator on before they can get air. They go through the ET tube, through the ventilator sockets, turn it on. When they do that for 2 hours or so, or 1 hour, they get very tired. They get very, very exhausted. So if you extubate them, they're gonna crash. Okay? So you gotta be on the lookout for that. I don't like doing that to COPD patients. But if you don't have COPD, they should do fine on CPAP. Okay? Any questions about CPAP? Winning procedures, win rate in decrements of 2 to 4, win FiO2 in decrements of 5 to 10%, win pressure support in decrements of 2 to 5, win PEEP in decrements of 2 to 5, win tidal volume in decrements of 50 to 100. Okay? The bottom line here is you always do it gradually. That's all. Like now I said, win respiratory rate in decrements of 2 to 4, not necessarily. If my patient is at a rate of 12, they want me to turn it down to 11 versus turning it down to 10. I will pick turn it down to 11 first, okay, before you do 10. If you are going up, then you go up gradually on anything you can think of, not just mechanical ventilation. Monitoring patients' response to winning. Anytime you change something on the ventilator, the patient should react to it. You have to monitor to see what the patient is telling you. Heart rate. Well, I decreased my FiO2 from 60 to 40, and all of a sudden, the patient is tachycardic. What the patient is telling you is that what you just did now, I don't like it. Put it back. Okay? And here's another thing on the exam. Let's say that, you gotta remember this one here. Patient is on 60% oxygen, and then I dropped it down to 40%. And the patient gets very, very tachycardia, 130 per minute. Well, what you can do next is, you can say, well, if you didn't like 40%, how about if I turn it down to 45% instead of the 40? How about if I turn it down to 50? How about if I turn it down to 55? But you don't just go from 45 to 60. You're trying to win them, you're trying to make them come off the vent. You're putting them back where you get them. That's called setting the patient back. So you're going to try all this stuff. Well, you don't like 40, how about 45? Then I put it on 45, I'll monitor the heart rate. Well, you stay up, well, how about 50? And then if you don't do it, then you put them back where you get them. Remember that on the test. Walk-up breathing. Okay. Now you made a change, and then all of a sudden the patient is going. Okay. They're telling you that what you just did, they don't like it. You have to put it back. Oxygen saturation drops. That's not good. Patient becomes agitated and restless. That's not good. Okay. Respiratory rate goes from 12 to 10, and then you look at your patient everywhere on the bed. That's not good. You put it back. Okay. Fatigue. Blood pressure. Okay, you monitor your blood pressure. Your blood pressure goes up. That's not good. Okay, you have to put it back. Respiratory rate goes up. You have to put it back. So that's the way we monitor everything that we change on the ventilator. Okay. Winning parameters. Winning parameters are performed to determine readiness for extubation. Winning parameters must be within acceptable limit before the patient can be extubated. There's more names for that. They can call it, instead of winning parameters, they can call it physical assessment. Well, the doctor wants you to do a physical assessment now to this patient. Well, if you're not careful, you may be thinking that the doctor wants you to go and take the patient out to go and exercise. This is respiratory mechanics as well. Respiratory mechanics. So they can call it William parameters, they can call it extubation, mechanics. All the same. William parameters, respiratory mechanics, physical assessment. Look at my assessment, my spelling of assessment. How do you like that? I don't write it well, and then when I look the second time, I'm like, wow. Okay, extubation mechanics. Okay? All right, so these are the tests that we perform. We're going to check the patient's respiratory rate, spontaneous respiratory rate. We're going to check their spontaneous tidal volume. We're going to check their spontaneous minute volume. We're going to check their vital capacity and MIP. Those two will tell you about the strength of the patient's respiratory muscles. We're going to check on what is called the RSBI, Rapid Shallow Breathing Index. So we can either do all of that with the patient attached to the ventilator. Patient is still attached to the ventilator. We have the patient weighing down to the lowest level of pressure support, like 10 or 5. And then we check all those things while the patient is still attached. That is called closed circuit Williams parameters. Or we can detach the patient from the ventilator and just have the ET tube hanging out, and then we just hook up wherever we need to hook up to the ET tube to do it. That will call open circuit Williams parameters. So when the patient is still attached, we call it closed circuit. When the patient is detached from the ventilator to do it, we call it the open circuit Williams parameters. So the first one that we're going to go over is vital capacity. Vital capacity. Vital capacity is a way of determining the strength of the respiratory muscle. If you have normal vital capacity, it means that you can cough effectively. Your muscles are strong enough to cough effectively to clear your airways of secretions. You're in control of your airway. So to check that, the patient is going to do slow vital capacity. Now remember, there's a difference between slow vital capacity and forced vital capacity. What we're doing is bedside vital capacity, slow vital capacity. Breathe in all the way in, blow it all the way out, slowly and completely. That's what we're checking. A normal person should have several ways to write down what is normal for vital capacity. 4,500 milliliter, that's normal vital capacity. Or you can go 65 to 75 mils per kg. Like here and now, takes a breath, deep breath all the way in, and blows it out. You get that volume divided by your ideal body weight in kg, you should fall in this range. That's what it means. Or you can say that normal vital capacity is 10 times your tidal volume. 10 times your tidal volume is about what is normal vital capacity. Well, somebody has been on the ventilator for days. The ventilator has been breathing for them. They have not been using their diaphragm. Remember, we're measuring the strength of the respiratory muscle. So they are going to be weak. There's no way they're going to do this here. No way. So what we're saying is that if you can do 10 mils per kg or more, that would mean that you are ready to be extubated. So we tell you, come in a contact ventilator, Mr. Smith, take a deep breath, blow it all the way out. We're going to divide that tidal volume by their ideal body weight. If it is 10 mils per kg or more, then that's good. If it's below that, we can't extubate. We cannot extubate the patient. This is what we used to do it, the Rice respirometer. Y'all probably remember what it looked like, but we're gonna do it Tuesday anyway. Okay, take a deep breath all the way in, blow it all the way out, gradually back and forth. NIF, negative inspiratory force, or sometimes they call it NIP, maximum inspiratory pressure. It depends on how you're measuring. Maximum inspiratory pressure measures a positive number. And negative inspiratory force measures negative number. But they're the same. It's just, what you need to measure in that manometer, like that, that's how you're gonna set it. When the patient blows into it, it goes negative way, like that. You can set it in such a way that it will go this other way. Okay? So either way is fine. If you got 20 MIP, it's like you have negative 20 NIF. Okay? So that's the difference. One is positive, one is negative. Now, this here also measures the strength of the respiratory muscles. Now, I told you all before that if a patient with neuromuscular disease comes to the hospital, but they're still breathing fine, well, the doctor will order for you to monitor them with the MIP and the vital capacity. Every once in a while, you go there and have the patient do those two things. As long as you are getting good numbers, the patient doesn't need to be intubated. But as soon as one of them becomes abnormal, that's a sign that their respiratory muscles are getting weaker. Then you need to go ahead and intubate them. Okay? So, but now, this is what we're trying to do here is to see the amount of negative pressure that the patient can create to breathe. Okay? So we'll give them this manometer here. And right here in this tubing, this hooks up to the ET tube or the mouthpiece. There's a little hole here. We'll close it. We'll take your hand, put on your glove, you close it. You say, Mr. Smith, I want you to suck in as hard as you can. You are not going to get any air when you suck in. You occlude it. And then the patient goes like that, creates a negative pressure, and the needle will swing to a number. Okay? So, normal MIP or NIF, let's put it in negative number. Negative 60 to negative 100. Or MIP, 60 to 100, will be a positive number. And again, the patient has been on the ventilator. The ventilator has been breathing for the patient. So we can't expect them to go like that. They are very weak. So what we're saying here is that if you have less than negative 20, that's good. The more negative, the better. So negative 30 will be better than negative 20. Negative 80 will be better than negative 30 or negative 50. Okay? But now, if it's above negative 20, that's bad. We are going to intubate the patient. Okay, or we're not going to extubate the patient, either way. So if the patient is not already intubated, you have to intubate them. If the patient is already intubated, you cannot extubate them if it's greater than -20. Respiratory rate, we count that. We take the patient off the ventilator, we're doing the open circuit, and we just have them breathe for 1 minute, we count their respiratory rate. 80-20 is what we're looking for. It cannot be less than, 80-25, sorry. It cannot be less than 8, it cannot be greater than 25. Yeah, we give like 5 points above normal spontaneous respiratory rate because patients in the ICU don't feel good. They have all this needle going in at different angles. Okay? So you can't expect them to have normal respiratory rate. Tidal volume. Okay, spontaneous tidal volume, 5 to 8, 5 to 6 will be good. We'll give them the right respirometer and we'll tell them to breathe in and blow it back in there. And when we take that tidal volume that they blew out and divide it by their ideal body weight in kg, if it falls between 5 to 6 or 5 to 8, then that would be enough tidal volume for them. Okay? Mini volume, 5 to 10. Okay? Well, if it's greater than 10, it means that their metabolic rate is still very high. That will demand more oxygen, of which if you extubate the patient, they may not get that oxygen, they will have respiratory distress. Well, if it is less than 5, that's not good either because their CO2 is going to be rising because alveolar ventilation depends on mini volume. Okay, so but 5 to 10 is the acceptable range. RSBI, rapid shallow breathing index. Now, this one here is used to determine whether the patient is going to be tachypneic after extubation. And they're going to have high respiratory rates. Okay, that's what it tells you. Well, if you have high respiratory rates, eventually you're going to get tired and start having low respiratory rates. And your CO2 is going to start rising. So that one is less than 105. There's a formula for that. Less than 105. I'll ask you these on the exam or the quiz. You need to remember that is RSDI equals spontaneous rate divided by spontaneous mini volume in liter. For instance, I counted my patient's respiratory rates and they have 40. And then my patient's tidal volume is 500. So I'll change that to liter. That will be 0.5. Okay?
So it is
now-
tidal volume, right?
Huh?
It is tidal volume, right?
Tidal volume, yeah.
All right, you originally wrote minute volume, so I was confused for a moment.
Yeah, my tidal volume, oh, sorry.
Just making sure.
Sorry about that. Yeah, so tidal volume, yeah. 500 tidal volume converted to liter. So that will give me about 80 or so. So that's less than 105. So that would be good. Thank you for that. I didn't even know.
Just double checking.
Any questions about that?
I had one question about the net
Beneath?
area. So you said that it's less than -20 to extubate?
Negative 20 or less. meaning that it's more negative.
More negative.
Okay.
So negative 20, negative 30, negative,
Okay,
so it's like this if you look at the number line.
This is why I prefer MIP.
So this is 0 here, negative 20, negative 25, negative 30, and then over here you have, the positive number, 5, 6, 7. So in essence, negative 20 is greater than negative 30, because it's closer to 0.
okay.
But the more negative, the better. The more negative number you can create to break, the better. Okay?
Thank you.
Mhm. Dead space. We may want to check the dead space too, because remember, dead space is the amount of volume that doesn't go inside the alveolus, that doesn't take part in gas exchange. Well, if you're breathing in your tidal volume, and most of the tidal volume is staying up here and not participating in gas exchange, well, that's not good. So we want to make sure that the patient's VD-VT ratio is less than 60%. Normal is 25% to 30%, but for extubation, it's less than or equal to 60%. So if you have 60% of the volume that you are breathing in, staying in the dead space area, that would be good for extubation. Okay? But if you're not intubated, that's not good. It has to be between 25 to 30. Some books say 25 to 40. So you have to remember the extubation values. The extubation values. We know the formula for that, right?
Paco, pico, paco.
Mm-hmm. Paco minus pico over
It's
Paco.
not the same.
Everything CO2. Everything CO2. A to A gradients. I don't know if you did that, but we're gonna do it. If you forget some of the down the line. A to A gradient is PaO2 minus P small a. Oh, actually, you've been doing that for probably, right? Yeah, so you know it. So you figure out your P big O2 using the alveolar A equation, take away your P small a O2 from the blood gas, that gives you the A to A gradient. And then when you divide that by 20, that gives you your shunts, right? Well, this is MBRC now, okay? If you're taking that clinical simulation and they tell you to do extubation parameters, you have to select A to A gradient on 100%. You have to do it, okay? The reason they do that, I don't know. But because now, before you wean your patient to extubate, you should have weaned them down to 40% or less. But now they're telling you to check their A to A gradient on 100%. So it's like you're gonna have to put them back on 100%, calculate their A to A gradient and see what it is. Okay, so remember that you're gonna have to pick it, okay? Checking the A to A gradient on 100% before extubation, okay? Well, this is what is normal. It is 25 to 65 millimeter of mercury on 100%. And rheumate is 5 to 20. Okay? And rheumate is 5 to 20. Acceptable, less than 300 and 100%. For extubation, it has to be less than 350. So it's very high. Okay? Very high. Sometimes it's good to check the PF ratio. Now, normal PF ratio is 300 or greater, okay? If you take your 80 PaO2, the lowest your PaO2 can be divided by 0.1, 0.21, that's about 3 something, 390 or 380 something, okay? But now, for the MBRC, if you divide your PaO2 by your FiO2, and you have a number that is 300 and above, that's acceptable. And again, that means how much oxygen are you using to get this PaO2? That's what we're checking. How much oxygen are you using to get this PaO2? Okay? As long as the number is 300 and above, when you divide your PaO2 with your FiO2, then that's fine. Okay? Don't worry about the P small aO2 over P big aO2. That just tells you about diffusion. Shunt. Normal shunt is 5%. 5% of your cardiac output does not get involved in gas exchange. They go into those 3 veins that I told you. Once it pumps out from the left side, some of the blood will go into the pleural vein, bronchial vein, and then the bursting vein. 5% of that blood that got pumped out. So that's how we come up with the fact that normal shunt is 5%. Okay? But 20% or less is acceptable. 20% or less is acceptable. PEEP, before you can intubate your patient, you must wean them down to a PEEP below 10. Because if you don't, a PEEP of 10 is still a lot of pressure. It means that their oxygenation is good because they have high PEEP level. Remember, when you extubate them, they don't have that PEEP. So we want to wean them down to physiological PEEP, the amount of PEEP that everybody has. Anything less than 10 is physiological. Okay, so if the blood gases are good, everything is good about that patient, but they're still on a PEEP of 10, I can't extubate them. What I need to do is to turn down the PEEP to below 10, and then I monitor the patient. If they're still doing fine, then I can extubate them. Before you can extubate your patient, you must wean the FiO2 down to 40% or less. 40%. Greater than 40% is high FiO2. It means that once you extubate the patient, the patient is only going to be getting, eventually your goal is to wean them down to room air. So if they have been oxygenating on 45%, now you have them on room air, how in the world are they going to oxygenate? So we want to get it as close as possible to room air before we extubate them. Extubation procedures. You're going to confirm your order, you gather your equipment and set it up. You don't extubate your patient and then begin to set up your equipment. It doesn't work that way. You're going to set everything up, have everything ready, your Yonka is there, everything, before you try to do that. Okay? Set up oxygen device. Cool mist is preferred. Cool mist. The reason for that is because the entire time the patient has been intubated, that ET tube is hanging on top of the vocal cords. That whole time, that ET tube is resting on top of it. So once you remove that ET tube, the vocal cord is going to spasm. It will spasm and begin to swell up. That's what causes that stridor. But now, if we give them cool mist, that will help reduce the swelling. Okay, it will help reduce the swelling. That's why cool mist is preferred. If they have been intubated for more than 24 hours, you gotta do cool mist. What FiO2 do you estimate them to? Well, the same ventilator FiO2. If you wind them down to 40%, then you're going to estimate them to 40% aerosol mask. If you wind them down to 30%, you're going to estimate them to 30% aerosol mask. Sometimes on the exam they can be funny with that though, because everybody knows what I just told you. So look at this here now. Let's say that I wind my patient down to 30%, and then I'm going to estimate them. Well, I would be looking for 30% to pick, but I don't see 30%. All that I can see is 35%. That's the lowest. That's not the ventilator FiO2, it was 30%. But I can go ahead and pick this. Because sometimes they will make it like 5 points above the ventilator FiO2. But it cannot go above 40 now. Okay? When you intubate somebody, you decrease their space. Intubation decreases their space because the diameter of the ET tube is smaller than the diameter of the trachea. When you intubate the patient, their space goes back up. Well, if their space goes up, oxygen goes down. Because their space means that you're breathing CO2. Anytime CO2 goes up, oxygen goes down. Anytime CO2 goes down, oxygen goes up. So what they're going to do for that dead space that just went up slightly, because you just intubated your patient, is to add a little bit more oxygen so that you're not hypoxemic. That's what they're doing. So if you don't see the ventilator FiO2, then pick another FiO2 that is slightly above the ventilator FiO2. That will work. Instruct your patient. Mr. Smith, I'm from respiratory therapy. I want to get that tube out of your throat. Keep it simple. Keep it simple, stupid. That's what I said. Keep it simple, stupid. But now if you go there and say, well, I'm from BIMA and I'm in respiratory therapy program, I want to extubate you. I go, what? You're going to do what? Extubate? What is that? Okay, so now you suction your patient orally and tracheally. You know, people forget to do oral suctioning. You have a lot of secretions on top of the calf that has been there for days. The secretions are rotting. If you don't suction it out with a Yunker, once you deflate your calf, everything goes back down. So that's very important. And then, after you have suctioned them, tracheally and orally, then you deflate the calf. And then you encourage the patient to deep breathe. Okay? And then at peak inspiration, you remove the ET tube. Look, don't tell the patient to cough when you are removing the ET tube. Don't tell them cough, cough. Some therapists do that, right? Cough, cough. No, cough is an explosion of air through a closed airway. And they're trying to do that, you're trying to move the ET tube. You can damage your vocal cords. What you need to do is you tell them to take a deep breath, you remove the ET tube, and then you tell them to cough. Okay? And by the way, the best answer on the exam is take a deep breath and hold it. That's the best answer. Because now what they're going to do, they take a deep breath, hold it, the vocal cord is this way, gives you time to patiently remove the ET tube. But now, if you tell them to just take a deep breath, they can go shh, like that. So you are trying to drag the ET tube when the airway is already closed. So you say, take a deep breath and hold it. They go like that. And then you move the ET tube. And then you tell them to cough. You put Yonka in your mouth and suction out their oral secretions. Then you assess the breath sounds. Now, look, everything is not racemic epinephrine. I want to tell you that. Because now, I know some people go, well, you know, they are wheezing, so let's give them racemic epinephrine because I just intubated them. Well, they have bronchi, yeah, we're going to give them racemic epinephrine. No, it doesn't work that way. The treatment that you give to the patient after intubation is based on the type of breath sounds that you're hearing. Okay? If I'm hearing wheezing, bilateral wheezing, well, the answer is to give them a bronchodilator. If I'm hearing coarse bronchi, well, what it means is that some of the secretions on top of the cough rolled back down into their airway. You know what? I'm going to do nasal suction right away. Do it fast enough because what you got there is another pneumonia. You just reintroduced bacteria into their lungs. So you have to be fast about that. Suction the patient. And then, if you're hearing crackles, you don't give them racemic epinephrine. What you give to them is incentive spirometer. They want to do deep breathing or IPPB. And then if you're hearing stridor, then you give them racemic epinephrine. Well, sometimes the stridor may not even develop until 35 to 45 minutes after that. Because, you know, the team may not start swelling up right away. So that's why you have to come back and assess your patient. Well, if you're hearing mild stridor and the patient has distress with it, the answer is cool mist. Okay? Maybe racemic epinephrine, maybe. Okay? You give them humidified oxygen. That's the number one thing, by the way, that you want to make sure is in that cool mist. Oxygen, humidified oxygen. If they have moderate stridor, well, the first thing you give to them is oxygen, humidified oxygen, which is cool mist. They come together. And then definitely racemic epinephrine. If they have severe stridor, then that means that the swelling now has gotten so big that their airway may close up if you don't hurry up. What we're going to do is we're going to re-intubate the patient. Okay? Here's two more words for that on the exam. They may say that you just intubated your patient and they have audible stridor. Now, audible stridor means that you can hear it without your stethoscope. If you can hear it without your stethoscope, that's very serious. It's a lot of swelling there. You have to go ahead and reintubate the patient. Or sometimes they may say, marked stridor. Marked stridor, that word on the MDLC means you better do something now. Any questions about winning parameters and